Good afternoon to everyone and welcome. Thank you for being with us today for the BREE Collaborative Implementation webinar on partnering with schools in youth suicide prevention. I am Amy Etzel, Implementation Manager with the BREE Collaborative. Before we begin, just a little housekeeping. You are all on mute and will be throughout the webinar. Today's speakers and I would love your participation in a question and answer discussion after their presentations. If you have comments or questions that come up while they're speaking, please feel free to type them into the Q&A box and I will use them to facilitate our session after their presentations. I will also try to check the chat box, but we'll be looking primarily at the Q&A box. You can find this at the bottom of your screen. So to start off, I wanted to give just a little bit of background on the BREE Collaborative itself and our guideline development process. We are a public-private group in Washington State formed by our state legislature in 2011. We are named for Dr. Robert Bree, who was a radiologist at Harborview and a leader in the area of inappropriate imaging for lower back pain. Dr. Bree died by suicide in 2011, and our work around suicide feels especially meaningful in his memory. Our goal is to improve healthcare quality, outcomes, affordability, and equity throughout Washington State. Our collaborative members are appointed by our state governor and represent a variety of stakeholders in the healthcare landscape, representing health plans, public health purchasers like our state Medicaid agency, private purchasers such as Boeing and SEIU 775, as well as representatives from delivery systems across the state and other quality improvement organizations. This is a group of people and roles that traditionally have competing business interests and don't always play nice together. So I really love our model of coming together and finding ways to collaborate on important healthcare topics. Every year, we select 4 or 5 healthcare topics that have variation in delivery or outcomes, that are used inappropriately or too often, that maybe are not used enough, or that might have a patient safety issue or an equity issue that our community cannot address alone. Our recommendations are formed by work groups made up of community members with expertise in that selected topic. This collection of volunteers meets for about 9 to 12 months to review published literature, guidelines from specialty societies, the work of other quality improvement organizations or national entities, and also relevant programs and policies within our own Washington State delivery systems. They then produce a best practice guideline and report that's put forth to our medical community at large for a public comment period and then eventual adoption. Our main implementation pathway has been through the Healthcare Authority, our state Medicaid agency, who writes our recommendations into their contracts. Beyond this, our implementation efforts have been fairly ambiguous in terms of how and in what way our work is used or not used. So I was brought on to join the BREE Collaborative in September of last year to put some targeted effort into this implementation piece, which brings us here today. I've been offering monthly webinars on topics related to our guidelines since January of this year. We offered a webinar in February on this specific suicide care guideline that we created, which was recorded and is available on our YouTube channel as well as on our website, along with all of our other previous webinars. This one is also being recorded and will be added to this collection next week, and we'll be emailing this out along with a link to our previous recorded webinars later sometime next week. So, as you can see, we have worked on a wide variety of topics, starting with obstetrics, looking at appropriate C-sections, and have also developed best practice guidelines for topics such as low back pain, end-of-life care, and behavioral health integration into primary care. We've also just identified our topics for 2021, which will be telehealth, cervical cancer screening, opioids in the elderly, and then a re-review of our total joint bundle recommendation. Our suicide care report and recommendation was adopted in 2018 by our community. Generally, the structure of our reports and guidelines is framed around specific focus areas. And so here on your screen, you see our 6 focus areas that the suicide care recommendation is framed around. The recommendation is geared toward a traditional primary care setting, not necessarily the unique setting of school-based care, but there are common elements in our recommendations for suicide care and prevention that can be applicable to a school setting. Rachel and Sophie will highlight and talk through these later on in the hour. As part of the BREEZE implementation efforts, I've been developing some starting ground implementation resources. These will be emailed out with the slides and the recording to our webinar next week. So here is our implementation resource for the suicide care report and recommendation. It's an implementation checklist for clinic staff outlining the 6 focus areas, and then some various actionable steps and workflows clinics can take and develop toward implementation of our recommendation. The second page of the checklist has some additional resources that are called out in the full guideline itself, as well as some links to further information regarding the evidence-based treatment recommendations within the report. I'm not going to go too in depth on these focus areas so that I can leave time for our experts, Rachel and Sophie. And you can also view our February webinar that does a deeper dive into these focus areas, but I do want to highlight just a few things. Our first focus area really centers around the importance of identification of suicide risk and recommends annual screening for patients over the age of 13 for behavioral health conditions associated with increased suicide risk using a validated instrument. Now, I do want to recognize that clinicians fully realize screening is insufficient. Our work group members who created the report and those who gave me input on developing this checklist really struggle with the knowledge that just because someone does not self-identify with suicidal ideation does not mean they're not at risk. That said, our clinicians and the work group members still feel screening is better than not screening. Starting the conversation can be extremely helpful. I know Sophie's going to go into this later on as well. The second page of this checklist has some suggestions of tools to use. This could potentially be an area of collaboration for schools, particularly for students who may be living on their own or couch surfing and not necessarily linked in with a regular medical care outside of school where they would receive that annual screening. Another thing I wanted to highlight, focus area number 3 is about suicide risk management after risk has been identified and assessed. Within this area, we talk a lot about having very clearly defined roles for all care team members and written protocols for these roles and care pathways. Sophie's going to highlight later on in one of her case studies how not having these roles clearly defined can lead to patients maybe slipping through the cracks and contributes to suicide risk. And with our highly underfunded systems contributing to high staff turnovers, it's important to have these protocols written down and clearly defined so that the care pathways remain the same even if and when the players involved may change. I've also identified some basic core process measures, not patient outcome measures, but core process measures for clinics to focus in on, particularly for clinics that are in the beginning stages of developing a suicide care protocol. Again, this is a resource that's very much more relevant for a traditional primary care setting, but I'm sharing in case it may be useful in sparking thoughts and ideas for measurement within your efforts. Both of these resources will be emailed out with the slides and recordings. Okay. Now I will turn it over to our speakers for the day. First up, we have with us Rachel Matting, who is currently the School Mental Health Program Manager for Highline Public Schools, where she's working to integrate mental health into the educational framework, a multi-tiered system of support, or MTSS. Rachel completed her MS in community counseling at Mount Mary University. Prior to joining Highline Public Schools, Rachel spent 9 years with Seattle Public Schools, where she integrated mental health into school-based teams and provided clinical interventions for students. We also have speaking today Sophie Dahan, who received her master's in clinical mental health counseling from Seattle University. She currently serves as the behavioral health system navigator within Highline School District and has been a child, youth, and family counselor in a community mental health agency for 3 years. Her work focuses on crisis work and helping others understand how to navigate talking about suicide. Thank you both so much for being with us today. And Rachel, I will turn it over to you.
Thanks, Amy. Hi, everyone. I just want to start by saying thank you to the BREE Collaborative and Amy specifically for having this great idea for us to partner on this topic and for giving us the space and the opportunity to start this conversation. So I want to share with all of you a little bit about Highline Public Schools, just to kind of give you a framework of where we're coming from. Something really foundational to our organization that guides a lot of the work that we do is our Highline Promise, which is that every student in Highline Public Schools is known by name, strength, and need, and graduates prepared for the future that they choose. Currently in our system, we have just over 19,000 students in 33 schools, and among those 33 schools, we have families and students that speak over 101 different languages, so a very diverse district. And geographically, we cover all of the area that kind of creates a loop around SeaTac Airport in 5 different municipalities: Burien, Des Moines, SeaTac, Normandy Park, and White Center. So to introduce a little bit about why we're here, or why Amy and I thought we should all come together and discuss this topic, is that these statistics that you're looking at on your screen are ones that are familiar to both the field of healthcare and to the field of education, in that we know the prevalence of mental health disorders, and we understand that suicide is the 2nd leading cause of death for children ages 12 to 17. And so we wanted to get this conversation started because we're really doing a lot of the same work that can be aligned to impact the exact same outcomes. And I know that many of you have also seen the behavioral health forecast for Washington from the Department of Health, and how it anticipates that we're going into some months that are going to be really crucial, that we pay attention to the mental health of the youth in this state. We know that because of that, it's more important than ever that we're able to create a clear pathway for students to be referred by the school to mental health services, as well as to create opportunities for bidirectional communication. That's a new healthcare term that I learned in education. We tend to say collaboration. So for that bidirectional communication or collaboration, through that, we can hopefully best treat and educate our clients and students and prevent youth suicide. So for Highland Public Schools, this is brand new work for us, and we are really fortunate to have been awarded a grant from the Kaiser Foundation through the Thriving Schools Initiative that will help provide us resources to address this gap. So briefly, Thriving Schools Initiative is a national effort dedicated to improving the health of students, staff, and teachers in K-12 schools through a focus on healthy eating, active living, school employee wellness, and positive school climate. And I want to note as well, and something that I know Sophie's going to talk about a little bit later, is Kaiser Permanente was the organization that did the original ACEs study, and I know that all of us have definitely seen a shift toward talking about trauma-informed care and trauma-informed practices in our work. And so Kaiser was the first one to really create the research and the opportunity for us to understand the health outcomes that are created through childhood trauma. And we also know that the antidote to trauma is resilience. And so essentially what the grant work that Highland Public Schools is going to be doing is around helping to build in resilience opportunities for our students to be more resilient, So here are our grant goals, and essentially, without getting too deep into this, the work that Sophie and I and our growing team are going to be doing at the district level is in expanding our capacity to deliver and sustain school-based mental health services and supports through a trauma-informed MTSS framework, the multi-tiered systems of support, which we're going to talk about next, to improve mental health awareness and promotion, to strengthen school, family, community partnerships, to reduce barriers to engagement in behavioral health services and supports, and to expand our own organizational capacity to address staff mental health and wellness needs. As we know, both in healthcare and in education, that the folks that choose those career paths are often exposed to a higher level of vicarious or secondary trauma that impacts their own health outcomes. And so that is something that we are addressing as well. So I'm going to try to keep this brief and not go too deep into it for those of you that aren't from the education lens, but essentially the framework that schools are using, that Highline's using to review student data and make decisions based on what's best for students is called multi-tiered systems of support, or MTSS. And essentially it creates a structure for us to team across departments and review all kinds of student data. We're really moving toward looking at the whole child. And so thinking about ways that we are recognizing and tracking behaviors, social emotional wellness, as well as academic outcomes and how well they are able to access instruction in the educational setting. And so each one of these tiers typically represents a team or a group of teams that work to review that data and assign interventions to students based on those needs. So tier 1, the big red tier at the bottom, is representing all things that students receive. So it's the universal tier, prevention's included in this tier, and it really speaks to not only the instruction that students are receiving in school, but as well as sort of the environmental setting. Are students clear about what the expectations are? Is there a process and system designed to respond to behaviors that interrupt the learning environment, and so on? And so it's thought that about 80% of students will be able to access all of their core instruction in school within this tier 1 without requiring additional interventions. And at the same time, we also know that students sometimes do need additional supports to get what they need and access that. And so if we were able to identify in a tier 1 data review that a student was struggling with a particular concept academically, or struggling with behaviors that are interrupting their ability to access their learning time, then we might look at a small targeted group that could either be providing reteaching and instruction for a concept that was missed, or to address social skills, anxiety, various things that might come up that would interrupt their ability to learn. And then tier 3 is the highest level of intervention, the most intensive, and it's typically 1-to-1. And that could look like a behavior plan for a specific student around changing a particular behavior that inhibits their ability to learn, or it may be reteaching with a different curriculum or in a different method, a concept or a bunch of concepts that a student isn't able to grasp at that level. It's typically thought that at tier 2, 15 to 20% of students will fall into the category of requiring tier 2 interventions, and between 5 and 10 in tier 3. But ultimately, what this system is set up for is to help us also address the disparity that school districts were experiencing in terms of which students were referred for special education services and which students were receiving office referrals. And we know that those numbers have disparately showed that students of color are often referred for those services more than their white counterparts. So this is an opportunity for us to slow down and really think about how we're using data to inform the decisions that we're making, rather than responding to the behavior or the challenge in the moment. So the next slide is going to show the Interconnected Systems Framework, which is the work of the grant that Sophie and I are working on in Highline. And essentially on the left side, you'll see the little bar that says schools at the bottom. And those triangles under the school building are really representing that MTSS framework. There's some different acronyms in there that make up some of the more intricate pieces of that framework, which I won't get into. But essentially on that left side is what we've been doing. And what we're trying to do is to kind of marry the triangle on the right and the left by joining with community-based services, integrating behavioral health and mental health into the school system so that we can work together towards treating and providing early intervention for youth mental health challenges, as well as explicitly preventing youth suicide. So some of the strategies that we are currently using in Highline in terms of prevention are listed here. The first one is training for staff, and I know training for staff and universal screeners absolutely aligns with the focus area 1 that Amy was talking about earlier, in terms of making sure that everybody has the appropriate information and is competent to respond and recognize warning signs, etc. Universal screeners is something particularly during our distance learning that Highline is really trying to figure out a system for. And we're asking ourselves questions about those universal screeners. And I believe that same conversation is happening in healthcare too. Amy alluded to it earlier, just around, do we have the capacity to fulfill the needs that are reported? Do we feel like we're getting honest responses from self-reporting? What is the baseline data that we're comparing it to, because we're already in a distance learning model? And so really trying to be intentional about selecting screeners that will give us information that's crucial to us intervening in the areas where we need to. And so in addition to screening for sort of general social emotional wellness and mental health specifically, we are also doing universal screeners around basic needs, food insecurity, housing insecurity. Obviously, we know a lot of folks in our community are struggling amidst the pandemic to just get their basic needs met. And oftentimes the school is a big connector for that to happen. And so we want to make sure that, since even if we're not all in the school buildings, that folks still have the opportunity to access that. We do, in 3 of our high schools, we have another grant to use the Forefront or Learn curriculum from the University of Washington, which is explicit suicide prevention that high school students receive. In secondary schools, meaning middle and high schools, they have advisory classes, and during those classes, they're also getting social emotional learning and suicide prevention lessons and curriculum. We have another grant. As you can see, we're trying to piece this work together since it's not necessarily funded. And so in doing that, some of our strategies are a little scattered, but we want to make sure that we're doing the best that we can to support students at each of their developmental levels. And so in middle schools, we have the SBIRT grant, and I know those of you in the healthcare field may be familiar with that screening tool. Screening, brief, intervention, and referral to treatment, and every student is receiving that in our middle schools, thanks to the grant from King County. We also have something called Gaggle Alerts, which is particularly important now that all of our students are at home on technology, but it is a security management system that notifies the district when a student is searching the web for issues related to suicide or other things that might imply imminent self-harm or harm to others. The Gaggle alert pops up, it alerts someone at the district, and then the district response team is able to contact the parent or the student and intervene, and if appropriate, refer to resources in the community that can support further suicide prevention work. We also have a crisis response team at the district level that's made up primarily of our social work staff. And in addition to responding to crisis situations and intervening alongside school-based staff, the crisis response team is also responsible for postvention. So that, again, is aligning with Area 5 that Amy talked about earlier in terms of what happens after there is a completion and how do we infuse additional resources into the school setting to make sure that we're preventing contagion or missing someone who might be really struggling with the loss of a peer. And finally, cross-departmental collaboration between our school counselors, district social workers, and school nurses, most of whom are the ones that often interact with students when they are struggling with mental health or other challenges that might be leading them to express suicidal ideation. And so I now hopefully have given you a little background on what the schools are doing, and I'm going to turn it over to Sophie.
Thanks, Rachel. And thanks, Amy and the BRE Collaborative, for allowing us to be here to provide this really important information. So as Amy said, my name is Sophie DeHaan. I am the Behavioral Health Systems Navigator for Highline Public Schools, and I'm also a clinical mental health counselor in a community mental health agency and a mental health provider, so I work within the agency's crisis response team. So studies have found that ACEs, which Rachel talked a little bit about earlier, correlate with increased suicidality. In Washington State, only 20% of the students that we see have not had an adverse childhood experience. I bring this up to show the significance of why we're talking about increasing our knowledge and actual use of tools to talk about suicidality with youth. Next slide, please. So now we're going to talk about our 2 case studies. I'll tie aspects of the case studies to BRE Collaborative's focus areas to show how the 2 intersect. And after sharing each case study, I'll share what worked, what was helpful, and where improvements can be made. Next slide. So in the first case study, we start with a female high school student who immigrated to the US after other family members, including her caregiver, had done so. Due to the family moving away first, the student had a lack of that in-person relationship with their caregiver, who only spoke Vietnamese. The student was referred to a mental health agency for mental health support within the school setting. The agency counselor that the student was referred to ended up leaving the agency, and the client was then referred to an intern. While the student was working with the intern, the student attempted suicide. The student was hospitalized due to their attempt, and upon discharge from an inpatient program, the student was referred to a site provider outside of the agency for potential medication. The student was not clearly made aware of potential side effects or chances at changing their medication, so they just stopped taking it when they didn't like it. The student continued to work to support their family, and then they also started using substances. The student slowly stopped coming to school. The school was aware, and the school social worker reached out to the student and made a home visit. The social worker provided education about medication, the ability to make changes, and just reconnected with the student. Next slide, please. So in this example, we've explored the lack of effective and coordinated communication and how it can drag out an intervention. We've also identified that Bree's first focus area, identification of suicide risk, may have been identified, but it wasn't effectively either understood or communicated. This client being referred to an agency could be considered the second and third focus areas, like suicide risk management and treatment, if that suicidality was known. If that wasn't known, if it wasn't communicated, then we can't really consider that being management and treatment. Once the referral was made, there was a lack of follow-up and communication between the school and the agency partnerships. Was the school counselor aware that the student was suicidal? Was that identified and conveyed in the referral? Questions like that. As outlined in Focus Area 5, there was also a lack of follow-up with the student by school staff and communication with the family, potentially due to language and cultural barriers. The social worker was only able to reach out to the student due to their own availability and resources, and it's not really an intervention that we can rely on. In an ideal situation, if everyone's been informed of all the pieces, individuals may feel able to more efficiently and effectively intervene. What can be done to provide a continuity of care? This also speaks to how overburdened these fields are. Teachers, school staff, mental health counselors, providers, as well as how significant the needs of the students are. A variety of cultures, languages, ethnicities, religions, practices, gender identity, sexual identity, socioeconomic statuses are represented by these youth, which also increases that feeling of needing to stretch oneself to meet everyone's needs, especially if we find ourselves identifying in ways that maybe other people don't. We stretch ourselves more to meet with people where they are, especially if we feel like they're not getting that need met somewhere else. So can partnerships help to remove some burden on each individual as well as meet the needs of students equitably? Part of my role is to help educators educate, and teachers are absolutely a pathway and sometimes the first, potentially the only contact a student or their family feels they have with the school to identify a potential need for an increased intervention. Next slide, please. So in this next case study, a male middle school student was again referred by a school counselor to an agency within the school setting. Because of an established relationship that the agency developed with the school counselor felt really comfortable making that referral. The agency counselor provided regular updates about how the client felt they were doing, progress on goals, all that stuff to the school counselor. As needed, there was no excess information. Of course, we had a release of information for the school, the counselors, the social workers that was signed by the student, which also brings in the fact that there are really unique circumstances with our youth who are old enough to consent to services on their own and without family involvement. But we'll have to talk about that another time. The student made a statement to a teacher at the school about having a plan and intent to take his own life. The teacher then communicated this to the school counselor. Even though the student was referred to the agency for suicidal ideation, due to the relationship that had been they were not referred for suicidal ideation. Due to the relationship that had been formed, the school counselor immediately reached out to the agency counselor, who was able to come to the school to complete a suicide assessment. That meets those brief focus areas of assessing and then managing that suicide risk. The agency counselor was able to safety plan with the student on school campus and in collaboration with the school counselor, who was able to communicate with the student's mom, who then came to school, and then she was part of the safety plan too. Again, we're meeting that, not just that suicide risk management, but also that treatment focus area of the BRE collaborative. The student went home from school with a safety plan, The agency counselor scheduled and attended a psych eval, and the mom and the student were able to attend that psych eval, and then the school counselor was aware of the psych eval. Next slide. So in this example, a model of continuity of care was followed, as well as communication and follow-up with those involved as needed. Next slide, please. So how do we as providers and educators enhance our comfort level to identify a need for increased intervention as it relates to client or student suicidality, right? Those thoughts, those risks of suicide. First, familiarize yourself and your community with factors of increased risks or signs of potential suicidal ideation. I found this mnemonic that I feel like is really helpful. So the word facts, right? Feelings. What feelings are the students or clients communicating? What actions are they displaying? Have there been changes in their behaviors? Are they withdrawing? Are they angry? And maybe you hadn't seen that before. Have they made threats about suicide? Are there new or changing stressful situations in their life? And then let's start those conversations. Let's ask those students and clients how they're feeling. So before I go too in depth, we're going to watch a short, about 1.5-minute video about starting that conversation.
Assuming I can make it work, which I thought I had embedded. Let's see here. I apologize if we're not able. It worked when I practiced it this morning.
No worries.
We may have to email this out later. I am so sorry, Sophie.
No, it's no worries. So in the video, she talks about like point blank, just asking if they're feeling suicidal, if they want to kill or harm themselves. These can be like really unnerving questions to ask. And the questions can totally unintentionally come off contributing to that stigma or coming off as judgmental. So one important change that I do want to point out when we're talking about destigmatizing how we talk about suicide is that recommendation to not say commit suicide. When we hear the word commit, we often think criminalization, a crime, right? Furthering that shame and stigma associated with thinking and talking about suicide. And that could even potentially contribute to student or patients or clients hiding those thoughts instead of feeling able to freely express or share them. So instead, could we think about suicide as more of a public health concern? In mental health, we use the words attempted, completed, or died by suicide. Sorry, Amy, I forgot to say next. This slide is great.
Don't worry.
To feel more comfortable talking about suicide or suicidality with students and clients, I'd recommend just practicing asking these questions. Maybe you and a colleague get together and you practice asking, are you feeling sad or depressed? Are you thinking about hurting or killing yourself? Have you ever thought about hurting or killing yourself? Maybe you practice in the mirror just to get comfortable with saying those words. There's several assessments you can use. There's some recommended by the school district within a clinic to assess that suicidality in those students and those clients and those patients that we have. You want to familiarize yourself with the questions that you need to ask. I personally like to have a piece of paper in front of me. Makes me feel more confident in the difficult stuff I'm asking. Is there a way that these questions could become part of like a more frequent check-in that you have with your students or clients? You know, maybe not every day, maybe you don't see them every day, maybe you don't interact with them every day, but implementing them some way within that. And also, how do we ask these questions or talk about this in a way that's culturally responsive? Are you able to acknowledge and respect the students or clients or patients' religious or spiritual beliefs and views, including like the attributions and the taboos that we think about within each individual's culture regarding asking these questions and talking about suicide? You can go to the next slide, please. So another key component of intervention prior to even assessing that risk of suicide, maybe even within the first tier of that MTSS, the multi-tiered system that Rachel was talking about, is helping youth build resiliency. As a clinician, I work almost exclusively with teens, and we're all really snarky and sarcastic, which builds trust in our relationship. Often I just name that feeling, I validate them, normalize that what they're experiencing is totally fine, or I just acknowledge the really difficult situation that they're going through. Often, through no one in particular's fault, youth don't get to hear that acknowledgement for the things they deal with. If we could start there, we could start to help them build that resiliency. Resiliency can look like a lot of things. It looks like an increase in self-esteem, the ability to problem solve, being empathic toward and with others, even setting realistic goals. Are there ways you would feel comfortable implementing this in a classroom? Maybe even a virtual classroom, right? Because everyone's online right now. What about in your clinical setting? You know, is this something that you guys could talk about as part of a treatment goal? Could asking what a goal for the day is be a way to start those conversations? Could you start conversations asking how a person feels about themselves? Could you provide praise to students or patients or for taking those steps that they need to take to solve their own problems? And so now I think Rachel's going to talk about some of those opportunities for partnerships.
Thank you. Essentially what we want to do, and kind of like starting to wrap up our conversation today, is talking about some opportunities to move this work forward through a partnership between the education system and community healthcare. And I will be totally transparent in saying that we don't have all the answers to that, and we absolutely want your help and want to engage you in this work. It's a little bit stating the obvious, but we know that being physically and mentally healthy is an indicator of future academic success, and conversely, that academic success is linked to better health outcomes. So ultimately, the work that we are all doing together is really striving for the same goal. And because we know that we work in two industries that are often short on resources and time, thinking about ways that we can partner to do this work more efficiently and to hopefully impact more youth in our state. So our first idea that we identified is starting the conversation. And I know a lot of you, both in community health and in the education system, have these conversations with students and with families around partnering. And so I want to encourage you to do that. I know that sometimes time is really an enormous barrier to doing all of the things that we would love to do. And I would still encourage you that if you have a school-age youth that comes in for healthcare and expresses any challenges at school, please feel free to suggest to the family or to the youth that the school communicate with you. And I can speak for Highline Public Schools in that we are absolutely always really happy to work with providers who can share information as needed and as appropriate that can help us better educate and support our students. And we love doing the same for you. So I just want to also note that includes the ROIs, or releases of information. And I want to say thank you to all of the providers and to the healthcare, community healthcare folks that have those at the ready to hand and put in front of a youth or parent on the spot, because we know that they can be hard to track down once someone takes them home and we try to get them back, at least on the school end. So I want to say thank you in advance for all of that. And then I want to also share that the MTSS and the Interconnected Systems Framework that I talked about a bit earlier, those teams, according to our best practice protocol, should have the involvement of community-based members. And so that is part of the work that Sophie and I are doing, is to figure out a way that we can help engage those of you in community health and community mental health to sit on those teams and help us review student data and help us catch things, intervene early, and prevent outcomes for youth that are unwanted, specifically around mental health and suicide. So I know I'm just going to give a little shameless plug here for Highline, since that's where we're from. If you are with a community organization and you're interested in partnering with these teams or learning more about how you can, I know Amy's going to send out the slides later in the video, and she will share contact information for Sophie and I. Please feel free to reach out to us. And for those of you that are outside of our region and doesn't serve the area that we work in, please reach out to your district or to local schools in your area and find out what level of involvement they're interested in having, or if you're getting regular communication from a school about students that you see there. Absolutely reach out and see how you can join the team as part of the conversation. Again, I know that time is a huge barrier to that, and everybody in community healthcare is busy, folks in education are busy, and so finding the time to do that, at least initially, and orienting ourselves to create opportunities for shared language will take a little bit of time, but eventually the hope is that this process becomes even more efficient and has even more successful outcomes for youth in Washington.
I think that's so true, because we're all ultimately serving the same population, just catching them in different arenas. And again, particularly the students that maybe aren't linked with a medical home, they're mainly in school, and those are mainly the people and the educators, staff, and counselors are the main sort of stable adults that they may have in their life that can help them link up with the services they need.
Mm-hmm.
Well, we did receive one question, so I will read it out and maybe both of you could take a stab at it. What are you doing or using to maintain or improve communication while providing remote learning and telehealth? Obviously, such a challenge in this COVID world that we're living in. Who wants to go first? You're both on mute in case either of you start talking.
Thank you for that heads up.
Yes.
I can take the stab at it first. I think that is something that we're actively struggling with and working on right now. And we're very lucky at Highline that we have a community partnership specialist who manages all of the relationships with the organizations at a higher level, and then folks that are assigned to school-based, to schools to offer services for that particular school's population. We obviously know that the technology, at least initially, was challenging to get out, make sure everyone had hotspots. That was kind of a barrier that we had to overcome initially and work through. And I think it seems like we are doing well in that regard, at least compared to when we first went to distance learning in the fall, or in the spring, excuse me. But I think what we are trying to do is create a system, and that system is a protocol, much like the one that Bree provided around suicide risk, is that we know exactly, regardless of who the person is that's intervening or working directly with the student, that there is a system in place to let them know what the next steps are and how to move forward with that. Additionally, we have the challenges of needing to incorporate translation services, having a high population of families who are really struggling with stable housing and that we're not able to get a hold of in a consistent manner. And so lots of teams across our system are really working on ways to make sure that we as a school, first and foremost, can connect with families and understand what's happening, and then to establish that system where they can hopefully receive uninterrupted mental health care.
Mm-hmm. Do you have anything to add, Sophie?
I was just going to say, as far as like using telehealth, we all are different agencies, some have access to Zoom, some have access to just doing phone calls. Most people aren't doing that in person, right? Everything is becoming mental health. And so within the assessing suicide risk, generally in intakes for mental health, it's not the first thing we ask, because we don't want everybody to feel put on the spot immediately, but it's within, an intake form that we ask about suicidal thoughts, right? And so the ideal would be that if it's not caught within the school, maybe it can be caught within that that collaborative, that bi-directional communication approach that we have, right? And so as far as maintaining and improving communication, I think that I've personally done a lot more outreach to my youth than maybe I ever had to. I used to go into the schools and I would just pull them out. We would do therapy and that would be easy. We're not in the schools anymore, right? We're not there. And so it's a lot of phone calls, a lot of like, I text them, I tell them I text them every Monday to schedule. And then the day they make their appointment, I'm like, hey, you still free? And then the hour before, I'm still, hey, you still free? And then I still get no-showed. So, it's still challenges that we're figuring out for sure. But having a lot of that resiliency in ourselves, to not take it as this is coming against me, right? I know that my kids aren't avoiding, maybe they are, but generally they're not avoiding me, right? And so building some of that resiliency in adults too, I think is really helpful.
Yeah. I also wonder if there's a way, part of my other work outside of these webinars is to work with primary care clinics around the state on integrating behavioral health into practice, and it has been extremely challenging, particularly in some of my rural communities. And they have been utilizing sort of like community newsletters that are going out in their neighborhood or within their communities. So I wonder if there's a way to partner with the PTA or other sort of school mailings that are going out to talk about some of what your offerings are. We've been utilizing some of the screening tools, have been going out with some of those newsletters so that people have a visual to look at as they're being screened. And that has produced some success in terms of just getting the, increased engagement and getting some data to take a look at where people are at currently. So we are ending quite early. It is only 11:45. So if
There's a question in the Q&A. Sorry. I was just going to say there's a question in the Q&A.
There is. Thank you. I'm so sorry. I have too many screens open. So there is another question. There was legislation passed this last session that required schools to have a crisis number text line on the back of all students' IDs from middle, high school, and college. Do you know what is happening with that, with students not being at school? Do they still get student IDs? I certainly do not know.
To be honest, I'm not sure that I do either. I don't know if students are being issued student IDs at this time. I do know that we have, our social work team is currently putting together a document or a flyer or some, I mean, obviously it'll go out electronically, but it's focusing on youth, providing them the Teen Link number, which is the number that kiddos can text. If they're feeling like they're in a crisis situation, all of our counselors are aware of that. But in terms of distributing student ID cards for the new school year, I don't know the answer to that question, but I'm happy to look into it and find out and report back.
Maybe we could look into that and try to get some information to send out when we send out the slides on Monday or Tuesday.
Absolutely.
If that's only a few days, but we'll send out what we can or what we find out. That's a really good question. Thanks for that, Laura. Any other final thoughts or things that you'd like to add, Rachel or Sophie? Feel free to say no pressure.
No, I want to say thank you again. I know, I know that we all are aware of the challenges that our communities are facing amid the pandemic and how important mental health care is in suicide prevention and in general. And so I just really appreciate the space to start this conversation. And I also want to welcome input from those of you that work in community healthcare about ways that opportunities for us to partner on your side. And for us, we want to be flexible. We want to work together efficiently to meet this outcome and to try to decrease youth suicide in Washington state. So please feel free to share ideas or reach out and discuss opportunities to partner. And I hope to be, attending some more BRE collaborative webinars to make sure that we have a good understanding of what's happening on the healthcare side as well.
Speaking of, just a plug, we do have the BRE Collaborative is offering a webinar next week around racial inequities and implicit bias in healthcare. There are researchers at the University of Washington who are working on developing some tools to measure some of those nonverbal cues that doctors and clinicians and providers use that can contribute to health disparities related to racial inequities and implicit bias. It's a super interesting topic, and the two researchers that are presenting are extremely knowledgeable and have been working in this space for almost 20 years, so they have great insight into what led us to the current crisis that we're kind of living in within healthcare disparities around race and inequities. Also put it in a plug, when you receive our slides, there is a link to sign up for our mailing list, which is where all of our webinar announcements come from, as well as any other BRE related news. And then